Everyone. I'm delighted to be able to speak with you about post-COVID ILD syndrome and very thankful for the Emirates Respiratory Society and Dr. Ashraf Al-Zabi for the invitation. This is something where we're going to start with what we know, which is not too much, and then delve into what we are best thinking about for post-COVID ILD syndrome and really post-COVID lung problems. First of all, I have no conflicts to declare for this talk. And now we'll go on to the agenda. We're going to talk a little bit about COVID-19 curiosities and implications, steroids in COVID-19, dealing with lung damage in a little bit on the examples, and then also antifibrotics. Now, what do we know about COVID? Well, we know that it's caused by the coronavirus, and you can see on the right is an electron micrograph of a coronavirus, and you can see where they got their name. There's a corona around the central virus that looks like sunspots erupting from the sun. So they gave it the name corona because it looks like a solar corona. Usually coronaviruses are not a big deal. They're long and large and enveloped viruses with a long single-strand RNA. And when they're large and enveloped, that means they're usually pretty easy to kill, meaning if they land somewhere and they dry out or become desiccated, that they die. So they have to be transmitted relatively quickly from one person to another. And the airborne transmission is how they're best transmitted. So if they usually infect the nose, you sneeze, they're in the air, and someone else inhales that particle, then you can get infected. Fomite transmission, meaning hard surfaces, are usually not much of a concern because we've learned that the virus rapidly desiccates and dies there. You'll remember at the beginning of the pandemic, people were wearing gloves in the grocery store and weren't touching their delivery food and leaving their packages out for long times. We've learned is much less of a concern. Although there is a report of a package being sent to Hong Kong and there being someone infected with COVID or SARS-CoV-2 based on that package, but that's a relatively rare event. We'll talk a little bit more about the virus that causes COVID-19 or the SARS-CoV-2 virus. The important aspects of the outside of the virus are these spike proteins, which make the corona. And the spike proteins are labeled as the S protein, and it consists of two areas, two regions or subunits. The first is subunit 1, and that's the part that gives it its trophism. And the SARS-CoV-2 S1 unit binds very strongly to the ACE2 receptor. And where's the ACE2 receptor? It has a large distribution and it's throughout the upper respiratory tract, importantly, the lower respiratory tract, GI, heart, kidney, and olfactory or nose. Usually the other less problematic coronaviruses don't bind so strongly to ACE2, they bind to other receptors, which are usually only in the nose and the upper respiratory. So this virus, the first thing is that it's very tricky in that its S protein, the S1 unit, binds to a protein found throughout the respiratory tract, meaning it can damage the lungs as well as the upper respiratory area. After the S1 subunit binds, the next thing that has to happen for the virus to fuse with the cell is you have to have the S1 and S2 regions cleaved. And that's done by furin for the SARS-CoV-2. Furin is found on all cells, which means that it's very easy it's cleaved at any time. The other thing is the S2 prime area must also be cleaved, and that's cleaved by the transmembrane protease serine 2 or TMPRSS2 region. And that's also expressed on epithelial cells. So you've got, once the virus binds, furin is found everywhere and cleaves S1 and S2. TMPRSS2 is expressed in epithelial cells, which is what respiratory cells are. So then you get the S1 prime cutting and cleavage, and therefore then you get the virus being enveloped by the host cell and the host cell becomes infected. So you can see This is a simple machine to infect not only the upper respiratory tract, but the entire respiratory tract. And then the virus is even sneakier because not only is it targeted to the lungs, but it interferes with the body's response. First of all, interferon is a cytokine made in the body that is upregulated to attack and viruses and kill cells that are infected with viruses and stimulate the immune system against viruses. SARS-CoV-2 specifically delays interferon production so that the virus can ramp up and make a lot of itself, leading to a very early high viral load. This also leads to a delayed and excessive cytokine storm. So people are infected, cells are attacked, and only then later on does the immune system ramp up and then really go to try to fight the virus, leading to secondary damage to the lung. So this is where frequently we see people who are infected who do okay for the first few days, but then 7 to 10 days, that magic 7 to 10 days that we've all heard about, after infection, they develop cytokine storm and much worsening lung dysfunction. So it's a rather curious and devious virus. And the virus causes COVID-19 and it causes gross lung damage throughout the lungs. So these are post-mortem lungs. And you can see on the left-hand side, all that yellow pus filling up the lungs. And in the bottom part, you see some hemorrhagic red areas. And this doesn't even look like lung anymore. It looks like liver, what we used to call hepatitization of the lung. There's no gas exchange occurring in these lungs that are affected not only by the virus, but by the body's delayed immune response to the virus. And you can see here's the damage. And what we call that is diffuse alveolar damage, meaning it's nonspecific. Basically, every epithelial cell is destroyed. It becomes garbage in the middle of the alveoli. The basement membrane is denuded, and you have big cells that are trying to re-epithelialize. And this is what we call DAD, diffuse alveolar damage. And if you've ever gotten lung biopsies on really sick people and it comes back DAD, you know that doesn't mean much. Basically, that just shows something bad happened to the lung, the damage is diffuse, and that person is not going to be doing too well. It's very much nonspecific. It's seen in almost in all viruses, but it just means that some bad things are happening. So when I've talked about the early reasons why the virus is so devious to cause problems. And we all know most viral infections, the body does get the upper hand, and most viral infections resolve on their own or with some of the new treatments. But we're here to talk about what happens when the patient will have an infection, they'll get better, but is there any persistent lung damage and how should we deal with that? Well, first of all, there have been some studies that have looked at this, and what they found is that at 60 days after discharge from the hospital, and this was a study in 38 hospitals in Michigan, so a large number, 23% of those patients who are discharged at 60 days will have some dyspnea with stares, and 14% will have an abnormal cough that they otherwise didn't have. So at 60 days, it's still relatively common to have problems after recovering from infection. Patients presenting with dyspnea post-COVID, in our experience here, we see a lot of these patients that almost all of them have a severe cough. So if they're going to have dyspnea, they're going to also have a severe cough that's exacerbated by any turbulent air moving through the airways. So deep breathing, when you have them take a breath to listen to auscultate their lungs, that will almost always cause a cough. And also, they say that they just can't take a deep breath. They feel as if there's a belt around their chest, which is curious because we see a lot of other interstitial lung diseases, IPF, chronic HP, sarcoid, and I've only had 1 or 2 of those patients out of thousands tell me they feel their chest is restricted. Maybe it's because that disease takes years to progress, but almost all the post-COVID dyspnea patients, when they have significant ILD, they tell me they just can't take a deep breath. They feel restricted. It's interesting. As expected, when these patients do have symptoms, they have abnormal imaging, and we'll get to that in a little bit. They have restriction on spirometry, and they have a reduced diffusion capacity. So nothing that you wouldn't expect. when you look at the specifics of ILD after someone has COVID, it's important first to understand what happens initially. So if you do a CT scan on everyone who has a COVID infection, 90% of those patients will have some element of lung damage on their CT, meaning they'll have an alveolar ground glass infiltrate, or they may even have a dense infiltrate, but almost everyone will have some abnormality on CT. And you'll remember at the beginning of the pandemic, when we didn't have so many tests, we would often find these patchy ground glass or opacities on CT scan before we were able to test them. Now, the good news is at 6 months, half of those patients and CT scans have completely recovered. So by 6 months, their lungs have gone back to normal, even if they look terrible with infection. 33% at 6 months, however, will have a reduced DLCO. That's not good. And 10% of the patients will have severe interstitial lung disease with severely reduced diffusion capacity at 6 months. So basically, if you have lung damage on your initial CT, up to 1 in 10 will have significant ILD at 6 months. 7% of the patients at 6 months will need supplemental O2. So these are people who are really impaired. And that's any type of supplemental O2, either with exertion, rest, or during sleep. And the other question is, if you have more severe COVID, is it a bigger risk of developing post-COVID ILD syndrome? And the answer, as one might expect, is yes. 70% of severely affected patients have some degree of interstitial lung disease at 6 months. So if you have a mild infection, you're most likely going to be one of those people who it goes away. But if you have a severe infection, you're at higher risk of having trouble. Now, the possible courses after post-COVID fibrosis, I've demonstrated in this little cartoon. So in the first 2 months, and that's just arbitrary, saying the first 2 months are the initial acute infection of viral production and the body's host immune response. And you can see that's that tan line with a big drop in lung function. Then you've got 4 other lines. The green line is what we want to get to, which is a rapid improvement in lung function leading to a good level of lung function at 6 months. The blue line is someone who has had also has a rapid increase, but their lung function doesn't go back to near normal or what we want it to be. So that's someone if we had a medicine that made them a little better earlier, but didn't affect the ultimate outcome. That would be like with acute HP. What we know from a couple small studies that were a long time ago now is that in acute HP, if you give prednisone, you'll hasten the lung recovery, but you won't affect the ultimate outcome of the lung recovery, in addition to removing the known offending antigen. So that's kind of like the acute HP story. Prednisone makes it better quicker, but it doesn't affect the ultimate outcome any more than taking away the antigen. The black line is the slowly improving line that slowly improves, and at 6 months you get suboptimal lung function. That's the one we don't want to. That's the one we want to avoid. And the red line is the even worse line. And this is the line where the lungs just don't get too much better because they're pretty much destroyed. And we do see that occasionally, and we'll talk about that a little bit. That's where not only does the lung lead to infiltrate and scarring, it pretty much destroys the whole lung, leaving basically cystic structures. So we know some studies, and we'll show those in a little bit, about oral corticosteroids providing benefit. But what about inhaled corticosteroids? We're lung doctors after all. We pretty much give inhaled corticosteroids to almost everything. Not true, but almost everything. So the first question is, this is an infection where you want an immune response. Do inhaled corticosteroids cause any harm? And that's a very good question. And at first we thought, oh my gosh, all of our bad asthmatics who are on inhaled corticosteroids, they might be increased risk of bad outcomes or death if they get COVID. And a study in England looked at this, and what they wanted to answer were 3 questions. One is, do inhaled corticosteroids increase the risk of getting infection? That's question 1. Do they increase the risk of going from infection to symptomatic infection? That's number 2. And number 3 is, if you do get symptomatic infections, do being on inhaled corticosteroids make things worse? What they found is that it did not worsen one possibility, 1, 2, or 3. So the good news is that your folks with asthma don't have to worry about having worse outcomes if they were to get COVID-19. What's also interesting is that the inhaled corticosteroids actually decrease lung expression of the ACE2 protein. So in a way, it might be protective because you've got less receptor for the virus to bind to, but that's speculative. COPD, though, is an independent risk factor of death. That's not surprising. You get a lot of inflammation and cellular destruction. If you have emphysema and really need those little terminal airways, you're going to be in trouble. The other question of, do they provide benefit? And that's on the right-hand side. This was also a study done in England. And what they did was they took patients who were 65 years or older and healthy, or 50 with any comorbidity. And during their infection with COVID, they either said, stay home or come to the hospital and we'll take care of you, or we're going to do that and we're going to add inhaled budesonide. And you can see the number of people who had cumulative recovery, the percent recovery, was faster, but no difference in ultimate recovery in people who use inhaled budesonide. So what this tells us is that in patients who have COVID, treating them with inhaled corticosteroids may lead to a little bit of a quicker resolution of disease, but does not affect the overall outcome. And the authors in this study therefore recommended against using inhaled corticosteroids for routine treatment of COVID infection. So that's sort of good news, sort of bad news. Inhaled corticosteroids don't cause harm, but they don't really provide a lot of benefit. Now, one of the good studies that first came out about benefits of treatments in COVID was early prednisone, showing that you decreased the need for invasive mechanical ventilation in patients. So you can see on the left-hand side is those who are on mechanical ventilation, and then the percent who died in the y-axis, and days since randomization on the x-axis. You can see usual care led to 40% death. Wow, that's terrible. Dexamethasone cut that down to the mid 20%. So prednisone 40 milliequivalent or prednisone 40 milligrams daily or the equivalent for 10 days was shown to increase survival in patients who were ventilated. And you can see the forest plot above there showing that in all patients, except those who didn't need oxygen, benefited from prednisone. So the rule is now, if you need supplemental oxygen, you also get 10 days of prednisone, 40 milligrams a day, or its equivalent. That was the first big improvement in COVID care. And it's good that we now use that as standard of care in folks who need supplemental oxygen. Now, this is the only study that's available right now looking at patients who have COVID-associated ILD and dyspnea after discharge. So what the authors in this study did was they took all 30 patients who had dyspnea and interstitial lung disease after 6 weeks after discharge, and they said, if prednisone orally worked well when they were initially ill, would it work to benefit them afterwards? And what they found in this study without a control group, that's the main problem, is you can see, first of all, on the left-hand side, you see the amount of steroid they gave on weeks 1 through 6. So week 1 there is week 7 after discharge. And you can see the average was somewhere between 20 and 30, about 27 milligrams a day. And it was rapidly tapered off. And you can look at the result of that. If you look at the FVC, percent or in liters, and the transfer capacity or DLCO in SI units or in percent predicted, you can see that the FVC and the diffusion capacity both improved with prednisone. Now, does this mean they improved more than if they weren't given prednisone? We don't know. Does it mean they improved faster than if they were given prednisone? Again, we don't know. But what we hope is that it's that green line, which is you get an ultimate higher outcome and you get a faster recovery. In our treatment at Cleveland Clinic Abu Dhabi, when we have patients who come in, 6 weeks or so after discharge with interstitial lung disease, reduced diffusion capacity, severe cough, we do use prednisone in a tapering dose, and the thought that it does hasten improvement. What can we learn from other ILDs? How do we treat other interstitial lung diseases, and might they affect how we should be treating post-COVID ILD? So this is an interstitial lung disease we all know a lot about. So this is idiopathic pulmonary fibrosis. It has the 4 characteristics that we have to see for a diagnosis of UIP on radiology. We have bibasilar subpleural reticular fibrotic changes with honeycomb cysts without significant air trapping or ground glass. So you need those 4 things. And they're all right here. And we know that we can treat IPF. We have 2 drugs that are approved to treat IPF, pirfenidone and nintedanib. And these are the summary results of the pivotal trials for both of those some years ago. And as they showed that they reduce the decline in FVC by about half. So we know that IPF is a progressive disease. We know that most of those people will die, half will die in 3 years. And we now know that pirfenidone and nintedanib will slow down that lung destruction. And from some aggregate studies, meta-analysis, we know that that will improve survival. Now, does that mean that these are going to help an idiopathic and COVID-associated interstitial lung disease? We don't know, because for the vast majority of our patients that we see, they do reach a plateau, but they don't have continuous decline like IPF. So we don't know if pirfenidone and nintedanib are going to benefit. What we do know is that there are about 5 trials going on right now to help answer that question. One of the other things we've learned about from idiopathic pulmonary fibrosis and the other interstitial lung diseases is we used to hope, and I use that word hope, we used to hope that, okay, we know IPF is bad, the fibrosis progresses and gets worse, but maybe other types of fibrosis are just fibrosis and don't get worse. And that question was answered when we looked at the control group of the Impulses trial for IPF. And what we found there is that, as we would expect, they had significant decline over 52 weeks in their lung function. But the INBUILD trial was people with fibrosis, but not a diagnosis of IPF. These are people who have connective tissue disease or hypersensitivity pneumonitis with fibrosis. And what they found there was that if you had fibrosis, even though you didn't have IPF, it was still bad. You still had progression of decrease in lung function and death within the 52 weeks. So that tells us that not only is IPF bad, but any type of fibrosis in the lung is bad. And when we look at that, we try to look at, there was one study which we all know about with nintedanib, and what they did was they looked at placebo, which is the light blue line showing the decline. And then they looked at nintedanib in folks that didn't have IPF, but either had a UIP-like pattern or didn't. And they found that both groups had less decline in their lung function when they were treated with nintedanib. What does this mean for post-COVID ILD? We don't exactly know, but in patients of mine in a Cleveland Clinic Abu Dhabi who have significant fibrotic lung disease after COVID, we have a long discussion with them about whether nintedanib may be a benefit for them. And what we talk about first are the risks and benefits. We're not sure of the benefits, but it's theoretical. But we know there are significant side effects, diarrhea, GI side effects, and also the cost of obtaining the medicine. So we go through those, and we have a few people who say, yes, I would like to try the treatment. We have also some who say, if it's not proven, I don't want it. So, but that's important to have that discussion because we receive those questions almost every day. Now we'll get to some examples in lung dysfunction. This is the first example, and this is a patient who presented in December with classic COVID. And you can see here some diffuse ground glass. Some is denser than other areas, but patchy, diffuse ground glass infiltrates throughout the lung. This person's in trouble, and they were on high amounts of supplemental oxygen. Then in January, you can see it's evolving. Some of the areas have become a little more dense. Some of the areas have become a little bit blacker, meaning less dense, or a little bit better. So this patient who came to us after their acute infection in January with this scan, we thought, the acute infection is gone, but they're still having significant symptoms. Maybe they would benefit from a prolonged course of oral corticosteroids, which is what we did. And you can see here, this is them in March after a prolonged course of oral corticosteroids, starting them on about half a mg per kilogram. And you can see marked decrease in the amount of lung that's opacified. And you see these band-like fibrotic areas that are subpleural. They're not right against the pleura, they're a little bit off. And you can see even better in June, the little bits of band-like abnormalities. We don't know if these are going to progress. We don't know if this is going to behave like fibrosis and connective tissue disease or chronic hypersensitivity pneumonitis, where all fibrosis is bad, but we're going to keep an eye on it. And this is where we do have those discussions. But again, we think that the prednisone probably hastens recovery. We don't know if it improves ultimate recovery. This is a second example. So this is a patient who had horrible COVID in the left lung. You can see it's completely opacified, and you've got these little air bronchograms there. That's all that's left. That's the only air in the left lower lobe there. This is terrible. The right lung, you can see some ground glass changes being affected, and this is on 16 December. Then on 3rd of January, some catastrophic changes. This patient was actually on ECMO. What happened is they blew a pneumothorax and had multiple chest tubes on the left side to try to evacuate that air, and the lung never came up. Why didn't the lung come up? Because it was a constant air leak and the lung was so consolidated. You can also see that on the right side, it looks terrible. There's a lot of ground glass there. It's much more dense. There's actually a small pneumothorax on the right also. Egads, this person's not doing well. They were actually on ECMO. What Zaid Zumot did, one of our pulmonologists here, who's an expert in endobronchial lung volume reduction and placing endobronchial lung valves, he placed a endobronchial lung valve on the left side, which stopped the air leak. You can see the left lung is now up. There's still a chest tube in place, but it's no longer leaking. And you can, what's amazing here is this is also just above the right dome of the diaphragm. You can see that that consolidated lung on the right is actually now aerated and it's open. And there are some areas that are going to probably be pretty normal, which is great. You can see on the right side, those dense infiltrates have started to organize and coalesce. The patient is on a prolonged course of steroids, and they were removed from ECMO, and they're getting a little bit better. What their ultimate lung function will be like, we don't know. So again, for post-COVID ILD, it's ILD so important, I have to say it twice up there in the title, is that steroids we think likely hasten improvement, but it's not proven. They likely reduce cough. We have no idea if the steroids increase the ultimate lung function that the person will achieve. And we also have no idea if nintedanib or pirfenidone increase ultimate lung function or prevent future decline. So that's a big question, which there are a lot of studies looking into that. We'll see what the results are. They're going to have to be powered very well to show anything because there is spontaneous improvement as we showed. So our treatment is we do treat post-COVID ILD with corticosteroids. We treat a little bit like organizing pneumonia, but shorter, usually half a mg per kg for 2 to 4 weeks, tapering. Dosage and durations are adjusted by the extent of the disease. Some folks come in with relatively mild ILD. They desaturate when walking, but they don't need supplemental oxygen, but they have a horrible cough. Those I do treat with oral corticosteroids, and it does help. I always give pneumocystis prophylaxis if I'm going to be above 15 milligrams for a prolonged period of time. You don't want to jump out of the frying pan into the fire. And our nintedanib and pirfenidone an option, we really don't know at this point. So that's the end of my talk. So thank you very much for the information. I hope I haven't led to more confusion and shed a little bit of light about where we are now. But I think in the coming year or two, A, unfortunately, it's probably going to be with us then, but B, we'll know more then. So thank you very much.